Welcome to the deep dive. All right, today we're diving straight into something really vital for those of you in critical care. Secondary thrombotic microangiopathies, TMAs.
Yeah, absolutely. Time is just so critical, isn't it? And clarity, well, that can be a lifesaver. So our goal here really is to deliver just that, the crucial insights from recent research on these secondary TMAs.
Kind of boiled down to what you really need to know in practice.
Exactly, distilled down.
Because, let's face it, these aren't straightforward diagnoses. Secondary TMAs are, well, they're a mixed bag of conditions. And the scary part is, even with the treatments we have, they still carry this really high risk of kidney failure and even death.
That's the core challenge. But what's really emerging, the sort of common thread we're seeing in the research, is the central role of complement dysregulation.
Ah, the complement system, part of the immune system, right?
Right, and it seems like it's going off track, going awry in many of these secondary TMAs. And there's more and more evidence suggesting that targeting it, using complement inhibition, could be a really important therapeutic strategy.
So we're talking about different initial problems, triggers that then somehow mess with the complement system.
Precisely, yeah. We'll be looking at TMAs cropping up during pregnancy or postpartum, those linked with hypertensive emergencies, really dangerous situations.
Okay.
Also, what happens after transplants, both solid organ and stem cell. Then there are TMAs tied to autoimmune diseases like lupus and scleroderma, drug-induced ones, even some linked to monoclonal gammopathies and infections.
Wow. Okay. That's a pretty wide net. So thinking about the critical care doc listening right now, what's the mission? What should they be taking away from our conversation today?
I think the big picture for your daily practice is getting a clearer handle on when and why you might need to consider complement inhibition, especially for those really severe refractory secondary TMA cases.
The ones where the standard stuff just isn't working.
Exactly. The patients who are really struggling. We want to offer maybe a more focused way to think about this treatment option.
Okay, let's start with the basics then. Thrombotic microangiopathy, TMA. What are we actually talking about at the core?
Fundamentally, it's about injury to the endothelium, that thin lining inside the small blood vessels. And that damage kicks off a cascade, leading to these tiny blood clots, microthrombi forming inside those small vessels.
And clinically, what are the classic red flags? What should make you think TMA in the ICU?
Well, the classic triad, the one we often learn, is microangiopathic hemolytic anemia, basically. Red blood cells getting shredded as they try to squeeze past these clots.
Ouch.
Yeah. Then thrombocytopenia, so a low platelet count because they're getting used up in the clots. And finally, signs of ischemic organ damage, particularly the kidneys, which are really sensitive to this.
But it's not always that neat triad, is it? I imagine it can be more subtle sometimes.
You're absolutely right. You can definitely see cases of, say, kidney-limited TMA. The damage is mostly in the kidney's microvasculature, but the blood counts might look, well, not too alarming initially.
In those cases.
A kidney biopsy often becomes really crucial to actually see the TMA changes in the tissue and make the diagnosis.
Okay. Now, the research sorts these TMAs based on what's driving them. Can you give us a quick rundown of the main categories? Where do the secondary ones fit?
Sure. Think of it like trying to find the root cause of that endothelial injury. So you have PDP thrombotic thrombocytopenic purpura, where the issue is with specific enzyme, abyl-MTS13.
Right.
Then there's Shiga toxin aHUS, usually linked to E. coli infections.
Right.
Then the big group we're focusing on today, secondary TMAs, where some other condition is the main driver. And finally, atypical aHUS, or aHUS, which we now understand is mostly driven by problems with the complement system itself.
Complement-mediated TMA, essentially.
Exactly. Though the terminology can get confusing, as you can imagine.
Yeah, I was going to say atypical, primary, secondary. It feels like the names can sometimes muddy the waters a bit in practice.
They absolutely can. It's something the field is constantly trying to refine to make the terminology clear and more useful clinically.
Okay, so let's use atypical aHUS as our sort of reference point. Why is understanding aHUS so important for getting a grip on these secondary TMAs?
Because aHUS is really the poster child, It's the clearest example we have of a disease where the primary problem is the complement system running wild, directly causing that microvascular damage, the TMA. It helped us unlock how this process works.
Okay, quick immunology refresher then. The complement system, what's its normal job?
Right, so complement is a key part of our innate immune system. It does a few crucial things. It helps tag bacteria so other immune cells can eat them. That's opsonization. It fuels inflammation to call immune cells to the scene. And it can directly punch holes in pathogens, killing them by forming something called the membrane attack complex, or MAC.
And how does it get switched on?
There are three main ways: the classical pathway, the lectin pathway, and the alternative pathway. But the important thing is they all kind of funnel down to one critical point, making an enzyme called C3 convertase. That enzyme then really ramps up the whole response.
But a system that powerful needs breaks, right? How does the body normally keep it from attacking our own cells?
Absolutely critical. We have a whole set of regulatory proteins, some floating in the blood, some stuck on our cell surfaces. Things like factor H, factor I, MCP, they're there to put the brakes on, to dampen the complement cascade and stop it from damaging healthy tissue.
Got it. Now, you mentioned aHUS is linked to problems here. There was a big discovery back in 1999.
Yeah, that was huge. Researchers found a strong link between problems in the CFH gene, which codes for factor H, and people developing aHUS. It was the first really solid genetic proof that messing up the alternative complement pathway could directly cause this type of TMA.
And that discovery sort of opened the floodgates, led to finding other genetic links.
It really did. After that, scientists identified other genetic issues, mutations that weaken other regulatory proteins, or mutations that actually make key complement proteins like C3 or factor B overactive. All roads leading to an alternative pathway that's just too revved up.
So, roughly how many aHUS patients have these kinds of underlying complement issues?
Estimates are around 60%. Either they've inherited a faulty gene involved in complement regulation, or they've developed antibodies that mistakenly attack their own factor H. Both scenarios lead to that uncontrolled alternative pathway activation.
And knowing this mechanism, knowing it was complement-driven, that led directly to targeted treatments.
It did, yeah. That understanding was the key to developing drugs like eculizumab and ravulizumab. They're antibodies designed to specifically block C5, a protein late in the complement cascade.
And blocking C5 prevents.
It prevents the formation of that membrane attack complex, the MAC, which is the bit that actually damages the cells. So you stop the destruction.
And the impact of these C5 inhibitors in aHUS has been pretty dramatic, hasn't it?
Oh, absolutely transformative. They've drastically cut the risk of kidney failure and death for aHUS patients, and they're also vital for stopping the disease from coming back after a kidney transplant.
Okay, here's a really practical question for our audience in critical care.
Yeah.
Is there a quick, reliable test, a biomarker that tells you this is definitely aHUS right at the start?
That's the million-dollar question, isn't it? And unfortunately, the answer is no, not really, not yet. There isn't one validated biomarker that gives you a definitive aHUS diagnosis on day one, or tells you for sure who needs C5 blockade immediately. And critically, you can have aHUS even if the initial complement blood tests look normal. So a normal profile doesn't rule it out.
Okay, so that brings us squarely back to the secondary TMAs. We understand aHUS better. We have targeted drugs for it. But what about these other TMAs, the ones triggered by different underlying problems?
Well, as the research really points out, these secondary TMAs, while maybe not getting the same spotlight historically as aHUS, they represent a huge unmet need, especially in critical care.
And just in terms of numbers, how common are they compared to aHUS?
Oh, much more common. Studies consistently show that secondary TMAs make up the bulk of all the TMA cases you're likely to encounter.
And the outcomes, even if you treat the underlying trigger, say, the infection or the autoimmune disease, they're not always great.
That's the really tough part clinically. Even when you manage the primary issue, these secondary TMAs still carry this really high-risk kidney failure in maybe a third of patients, and mortality rates that can push up towards 40%.
Wow.
It just underscores how urgently we need better treatments that target the TMA process itself in these situations.
And groups like KDIGO and ISN, the big kidney organizations, they've flagged this as important.
They have, yes. Both KDIGO and the ISN have specifically said, look, we need to evaluate complement inhibitors in secondary TMA. They see the potential there to improve outcomes.
I saw the paper mentioned a trial on ravulizumab that stopped early.
Yes, that's right. There was a phase 3 trial looking at ravulizumab across a broad range of secondary TMAs, but unfortunately it had trouble recruiting enough patients, so it was stopped.
Okay.
But importantly, there are other trials ongoing focusing on specific types of secondary TMA, so hopefully we'll get more specific answers from those.
Right. Let's drill down into some of those specifics then. Pregnancy and postpartum TMA, that sounds like a diagnostic nightmare, potentially overlapping with things like HELP syndrome.
Oh, absolutely. It's a major challenge. HELP syndrome, TTP, they can look very similar to TMA clinically, especially around delivery. But the key insight here is that there's a much higher risk of what is essentially atypical aHUS presenting specifically in the postpartum period.
Why then? What's special about the postpartum period regarding complement?
It seems to be a combination of things. Pregnancy itself involves a natural increase in complement activation.
Okay.
Then after delivery, you lose some placental factors that normally help keep complement in check. Plus, you have the sheer stress of pregnancy and delivery on the endothelium. It can all converge to unmask an underlying genetic susceptibility in the complement system that wasn't obvious before.
So genetics might be playing a bigger role in these pregnancy-linked TMAs than we used to think.
A much bigger role. Studies have found a really high frequency, somewhere between 40 and 70% of these rare complement gene variants in women who develop TMA around pregnancy.
Wow, that high.
Yeah. It's led many experts to basically reclassify a lot of these cases as complement-mediated TMA, just triggered by the stress of pregnancy.
So it's not just a consequence of, say, preeclampsia, but potentially a primary complement issue brought to light.
That's the shift in thinking. And historically, these pregnancy-related aHUS cases had really poor outcomes. Lots of kidney injury, progression to dialysis, and a high risk of it happening again in future pregnancies.
And the old standard treatment, plasma exchange, how did that fare?
Often not well. Therapeutic plasma exchange, or TPE, was frequently used, but it's largely ineffective for many with pregnancy-related aHUS, and kidney failure rates remain high despite it.
So what's the approach now with complement inhibitors?
The consensus is really shifting towards early use of C5 inhibitors, eculizumab or ravulizumab, for pregnancy-related aHUS. The data show excellent responses when started quickly. And importantly, we now have safety data supporting eculizumab use during pregnancy and breastfeeding, and ravulizumab looks promising postpartum too.
So for the critical care teams, what's the key takeaway? When should they strongly suspect complement-mediated TMA in a postpartum patient?
I think the critical point is this. If you have a postpartum patient maybe initially diagnosed with HLOP, but their platelet count stays severely low, or their kidney function isn't recovering after, say, 72 hours post-delivery, that should really raise your suspicion for an underlying complement-mediated TMA.
That's a really practical flag. Okay, let's switch gears to TMA linked with hypertensive emergency or malignant hypertension. The old thinking was just that the extreme pressure damaged the vessels, right?
That was a traditional view, yes. High shear stress damaging the endothelium. And while severe hypertension can certainly cause endothelial injury, there's more and more evidence suggesting that in many cases it might be the other way around. Meaning that an underlying primary complement defect might be driving the TMA, and the severe hypertension could actually be a manifestation of that TMA rather than just its cause.
That's a pretty big flip in perspective. What supports that idea?
Several things. Again, we're seeing a surprisingly high number of those rare complement gene variants in these patients. We see evidence of complement activation in their blood and tissues. They seem to have a higher risk of kidney failure and TMA recurrence after transplant. And crucially, many show significant improvement when treated with eculizumab.
But doesn't primary aHUS itself often present with severe hypertension? How do you tell them apart?
That's the tricky part. You're absolutely right. Severe hypertension and retinopathy are common in primary aHUS too. The research really stresses that clinical features alone, even looking at the eye changes or the kidney biopsy findings, often cannot reliably distinguish between a complement-mediated TMA presenting with hypertension and a TMA solely caused by the hypertension itself.
So in the ICU, you've got a patient with both hypertensive emergency and TMA signs. What's the game plan?
Priority one is always get that blood pressure down quickly and safely. Stop the ongoing damage. At the same time, you need to launch a full TMA workup to figure out the underlying cause.
And when does complement inhibition come into the picture?
The general guideline is, if you've got the blood pressure under control, but the TMA signs, platelets, kidney function aren't clearly improving within maybe 3 to 5 days, you should strongly consider starting a complement inhibitor.
Unless the kidney damage looks totally irreversible already.
Right, that's the main caveat. If the kidneys are already beyond recovery, the benefit is likely limited.
And plasma exchange in this setting.
Similar story to pregnancy-related aHUS, really. The results with TPE alone haven't been great. But there are case series suggesting eculizumab could be beneficial here. And there's actually an ongoing trial, the HYPER-SU trial, looking specifically at eculizumab for hypertension-associated TMA.
Okay, moving on to transplantation. TMA is a known headache after both solid organ and stem cell transplants. Let's start with solid organs, like kidneys. What drives TMA post-kidney transplant?
Oh, there are lots of potential culprits after a kidney transplant. You've got the injury from lack of blood flow during the surgery itself, ischemia reperfusion.
Uh-huh.
The immunosuppressant drugs, especially calcineurin inhibitors, can be toxic to the kidney vessels. Infections are common. And then there's rejection, both antibody-mediated and cellular. All can damage that delicate endothelium.
And distinguishing between these causes sounds tough.
It is. The differential is wide. Is it drug-induced? Is it CMV infection? Is it rejection? Did the patient's original aHUS come back? Or is it something new, what we call de novo TMA?
Let's talk about aHUS recurrence. That used to be a massive problem for transplanting these patients, right?
Huge problem. Historically, aHUS came back in about 60% of transplants, and when it did, graft loss was almost inevitable, like 90% of the time. But understanding the complement genetics has completely changed the game.
How so? How does knowing the genetics help prevent recurrence?
We now know the recurrence risk is tightly linked to the specific complement gene variant the patient has, whether they have anti-factor H antibodies, and if they lost a previous graft recurrence. Patients with high-risk variants in CFH, C3, CFB, or a history of recurrence are at very high risk.
So you can risk stratify them.
Exactly. And based on that risk, current guidelines recommend using prophylactic eculizumab starting before or right at transplant for those at high or even moderate risk. This has dramatically reduced recurrence rates and improved graft survival.
Okay, what about de novo TMA the first time it appears after the transplant? Is complement involved there too?
Well, de novo TMA happens in maybe 1 to 10% of kidney recipients. Often it's triggered by those common factors like drugs or infections. But interestingly, studies suggest that maybe up to 30% of these de novo cases might also have underlying complement gene variants.
So even if it wasn't apparent before, a predisposition might be lurking.
Potentially, yes. So the thinking now is if you have a case of de novo TMA post-transplant and you can't pin it on a clear cause like a drug or infection, or if it's really severe or not responding to standard management, you should definitely consider complement inhibition early on.
The paper also mentioned eculizumab being used for antibody-mediated rejection.
Yes, that's an interesting area. Eculizumab has shown some promise in treating TMA linked to antibody-mediated rejection, and it's even being explored preventatively in patients who are highly sensitized or getting ABO-incompatible transplants, where that type of rejection risk is higher.
Okay, let's shift to hematopoietic stem cell transplant, HSCT. Transplant-associated TMA or TA-TMA sounds like a really serious complication there.
It really is. TA-TMA affects maybe 15–20% of HSCT patients and carry high morbidity and mortality. The causes are complex. The intense chemoradiation beforehand, the immunosuppressants like CNIs, infections, graft versus host disease, GVHD. It's a perfect storm for endothelial injury.
And diagnosing it isn't always straightforward either.
No, it can be tricky. Sometimes it presents later, maybe without the classic low platelets or red cell fragments or obvious GVHD. Often a key sign might just be a steady rise in creatinine that doesn't respond to adjusting CNI doses or treating other potential kidney issues. High index of suspicion is needed.
Is there evidence linking complement to TA-TMA?
Yes, there's accumulating evidence. Things like finding C4D deposits in kidney capillaries, which points to classical or lectin pathway activation. Patients often have high levels of complement activation markers in their blood. Some studies also hint at anti-CFH antibodies or maybe more complement gene variants in these patients, though the exact role of those variants isn't always clear.
And treatment. Is there a standard approach?
Not really. There's no single established treatment. It's often supportive care, reducing CNI exposure, treating infections or GVHD. But there's growing interest and evidence for using complement inhibitors.
Specifically eculizumab and another one, narsoplimab.
Exactly. Studies have shown improved survival in high-risk TA-TMA patients treated with eculizumab. And narsoplimab, which targets MASP2 in the lectin pathway, had positive results in a key trial, improved TMA markers, organ function, and survival in high-risk patients. Others like ravulizumab, pegcetacoplan, nomacopan are also being looked at.
Okay, let's move into autoimmune diseases. Systemic lupus, SLE. How common is TMA in lupus nephritis?
It shows up in kidney biopsies in maybe 3 to 15% of lupus nephritis cases. And unfortunately, when it's there, it generally means a worse prognosis for the kidneys. The causes in lupus are likely mixed, the lupus activity itself driving immune complexes, maybe antiphospholipid antibodies playing a role, and direct complement activation.
And complement can get activated in different ways in lupus, right?
Definitely. Those immune complexes common in active lupus can fire up the classical pathway. You often see low C3 and C4 levels because of that. But you can also see anti-factor H antibodies in some SLE TMA patients, or even underlying complement gene variants adding to the dysregulation.
So initial management for TMA in active lupus.
Typically, you intensify the immunosuppression first, try to get the underlying lupus under better control.
And if that doesn't work, is that where complement blockers come in?
That's the idea. There are case reports and series showing eculizumab working well in the refractory SLE TMA. A pooled analysis actually showed good outcomes in over 90% of published cases treated with it.
Interesting.
There's also a novel drug, KP104,
Right.
to combine C5 antibody and factor H fusion protein being tested in a phase 2 trial specifically for SLE TMA. Plasma exchange, though. Limited evidence that helps much here.
Right. What about scleroderma renal crisis? Another scary autoimmune complication. Where does TMA fit in?
Scleroderma renal crisis is a really dangerous complication. Thankfully, only in about 10% of systemic sclerosis patients. It hits fast, sudden severe hypertension, TMA, and acute kidney injury. ACE inhibitors have improved things dramatically, but people still end up on dialysis or die from it.
Is complement thought to be involved there too?
There's some suggestive evidence. Things like low complement levels during a crisis, finding C5b9, the MAC, in skin biopsies, C40 deposits in kidney biopsies, correlating with worse outcomes. Some lab studies show patient serum can trigger C5b9 formation on endothelial cells. But how complement gets activated isn't fully clear yet.
ACE inhibitors remain the absolute cornerstone treatment, though.
Absolutely. But for those cases that just don't respond well to ACE inhibitors, where the kidney function keeps declining despite optimal treatment, there are case reports suggesting eculizumab might offer benefit, with many showing clinical improvement.
Okay, let's tackle antiphospholipid syndrome, APS. Known for clots, how does TMA feature?
TMA in APS typically shows up either as part of chronic kidney damage APS nephropathy with microthrombi, or in the much rarer but devastating catastrophic APS, or CAPS. CPS involves widespread clotting, including TMA, hitting multiple organs at once.
And we know complement activation is pretty central to APS itself, don't we?
Oh, absolutely central. Loads of evidence from animal models and human studies point to complement being critical for both the blood clots and the pregnancy problems in APS. You see higher levels of complement activation products, and it seems both classical and alternative pathways are involved.
How do the antiphospholipid antibodies actually trigger complement?
The main theory is that the anti-beta-2 glycoprotein I antibodies bind their target, and that complex kicks off the classical pathway. Then the alternative pathway jumps in to amplify it, generating inflammatory molecules and the MA, which damages endothelium and fuels more clotting.
Standard treatment for APS involves anticoagulation for the big clots. What about managing the TMA component specifically?
Outside of CPS, there isn't much specific guidance for TMA in APS nephropathy. For CPS itself, the standard is aggressive anticoagulation, steroids, often plasma exchange, and maybe IVG.
But given the strong complement link.
Exactly. Complement inhibition is increasingly considered for TAP-S cases that aren't responding based on the underlying biology in growing case reports. There was a key case where eculizumab prevented TMA recurrence after a kidney transplant in a CAP-S patient. The CAP-S registry data also suggests good recovery rates with eculizumab, especially in sicker patients with severe low platelets and hemolysis. And there's a trial ongoing looking at a C1's inhibitor for APS patients with kidney or skin issues.
We're covering a lot of ground. Let's talk about drug-induced TMA. How significant is this?
It's pretty significant, maybe around 10% of all TMA cases. And drugs can cause it in different ways. Some trigger antibodies, some are directly toxic to endothelial cells, some interfere with VEGF signaling, which is vital for kidney vessels, and some can even cause ADAMTS13 deficiency.
Any specific drug classes notorious for this?
Yeah, several well-known culprits. Certain chemotherapies like gemcitabine are classic examples. VEGF inhibitors used in cancer and eye conditions. Tyrosine kinase inhibitors, proteasome inhibitors, and even the newer immune checkpoint inhibitors.
Interestingly, the paper says underlying complement gene problems are less common in drug-induced TMA.
That seems to be the case, yes. Compared to, say, pregnancy-related or hypertension-associated TMA, finding those major pathogenic complement gene variants is less frequent here. But some patients do show signs of complement activation deposits in the kidney, low C3, especially with drugs like gemcitabine.
And the first step in treatment is obvious, right? Stop the drug.
Absolutely critical. Stop the offending agent. That's number one, and often the TMA resolves. But sometimes the recovery is slow, or the TMA is life-threatening right from the start.
So is there a role for complement inhibitors in those tough drug-induced cases?
There seems to be. A recent review looked at published cases where eculizumab was used for refractory drug-induced TMA, often as a short course. The results look pretty good. Decent rates of TMA recovery, getting patients off dialysis, and kidney function improvement with reasonable safety.
Okay, nearly there. The research also touched on monoclonal gammopathies and infections. What's the connection there?
Right, monoclonal gammopathies, finding an abnormal monoclonal protein, is surprisingly common in TMA patients, especially older adults, over 50. These patients often have complement abnormalities like low C3, normal C4, high SC5b9, pointing towards alternative or terminal pathway activation. Some lab work even shows the monoclonal protein itself can activate complement. How best to treat this is still unclear. Targeting complement, targeting the underlying plasma cell clone, or both. More research needed.
And infections.
Various infections can definitely trigger TMA, often with signs of complement activation. But using complement inhibitors when there's an active infection is tricky. You worry about hampering the immune response needed to clear the infection.
Makes sense.
Of course, infections can also be the trigger that unmasks an underlying complement defect in someone predisposed to aHUS. So the general thinking is, treat the infection first. If the TMA hangs around after the infection is cleared, then consider complement inhibition and definitely investigate for underlying complement issues.
This has been incredibly thorough. So, pulling it all together for clinical practice, what about working up the complement system in these secondary TMAs? When should our listeners think about testing?
Well, given how often we find complement gene variants or anti-CFH antibodies in pregnancy postpartum aHUS, hypertension-associated TMA, and de novo TMA post-transplant, it makes sense to consider genetic testing and antibody screening in basically all those patients. It helps confirm if complement is likely a primary driver.
And what does that testing typically involve?
Usually it's next-gen sequencing looking at the main complement genes, CFH, CFI, CD46, C3, CFB+ tests like MLPA to look for specific gene rearrangements. The results take time, maybe 4 or 6 weeks.
Which isn't helpful acutely.
Not acutely, no. But it's incredibly valuable later for prognosis, predicting relapse risk, transplant recurrence risk, and figuring out how long someone might need prophylactic C5 inhibition.
What are the other secondary TMAs, drug-induced, autoimmune-related, etc., where complement gene variants seem less common? Routine testing there.
Probably not routine broad screening for everyone in those categories.
Mm-hmm.
Pathogenic variants are just less frequently found. However, if you have a really severe or refractory case of, say, drug-induced TMA or scleroderma renal crisis, and you're thinking about using a complement inhibitor anyway, then testing might be reasonable. There could still be an underlying genetic susceptibility that got pushed over the edge by the trigger.
This has been super helpful, really practical. Let's try to summarize the absolute key messages for critical care teams.
I think the main point is that secondary TMAs are common, complex, and complement dysregulation is often a key player, maybe more often than we used to appreciate.
And some conditions we used to just call secondary, like pregnancy-related, hypertension-associated, de novo post-transplant TMA, are increasingly seen as fundamentally complement-mediated diseases where early C5 inhibition can make a huge difference.
Exactly. And for the other secondary TMAs, the focus is still treating the trigger first, absolutely. But complement inhibitors are becoming a real option, a rescue therapy, to consider when things are severe or just not getting better with standard care.
But we still need more solid evidence, right?
We absolutely do. We need good prospective trials to really pin down who benefits most for how long across all these different TMA types.
And practically, if you do use these inhibitors, need to remember vaccinations.
Crucial point. Meningococcal vaccination is essential before starting C5 inhibitors, and sometimes antibiotic prophylaxis too, because of the infection risk.
And it maybe be cautious about relying solely on plasma exchange.
Yeah, given the lack of strong evidence for it in many secondary TMAs and potential harms, it's generally not the go-to, especially if you suspect complement is involved.
So looking ahead, what's the research focusing on? What should clinicians keep an eye on?
A lot of work is going into identifying which patients will benefit most from complement blockade, finding better and faster biomarkers to guide treatment, figuring out optimal dosing and duration, and testing newer alternative complement inhibitors.
Okay, so maybe a final thought for our listeners in critical care. When you're faced with one of these really challenging, life-threatening secondary TMAs, could thinking more deeply about the complement system and potentially intervening there be the key to changing the odds for that patient?
It's definitely a critical question to ask. Considering these nuances, staying updated on the research, it could make all the difference.
A really important area. Thanks so much for walking us through this complex topic today, and thanks to all of you for joining us on the deep dive.